Okay, I start by submandibular, next swelling, submandibular first. Okay.
Who would like to start first, Dr. Iman, or Dr. Mariam, or Dr. Corollos?
Okay. Good evening. Hello.
Good evening, Dr.
This
Corollos.
is clinical examination station. Clinical examination station. It is important to know we have 4 topics for clinical examination: abdomen, and it is general abdominal examination. We have head and neck, and head and neck including the thyroid, including submandibular salivary gland, including cranial nerve, including cerebellum. And we have vascular, which is including venous and arterial system, so either peripheral vascular disease or varicose veins. And also have orthopedic, and the orthopedic is including hip examination, knee examination, spine examination. This is the main topic in clinical examination station. Although in some books you can find the topics about examine the chest, examine the heart, examine other organ. All this is not clinical examination. It is a part of the surgical physiology, and usually it is pre-operative assessment of the chest or pre-operative assessment of cardiology or cardiovascular. And of course, assessment, you can start by quick history and little examination, and the examiner show you ECG or respiratory function test of the other. This is just to avoid confusion. So only clinical examination skills or clinical examination in exam is for station. Okay, so we can start by first candid, and this is a case of the submandibular gland in the most of the center. Usually it is written outside. You have a patient, they have swelling in right or left submandibular regions, and they ask you to examine the patient. Because in some country it is difficult to have a patient, a real patient with submandibular, because submandibular swelling or submandibular salivary gland is not a common disease. So they usually, when you enter the station, we tell you you are lucky because the patient today, the swelling disappear. I just you a picture of the swelling, but if you don't have a swelling in exam, you just inspection and the others. Okay, so anyone can start.
Who would like to start? Corollos, do you like to start?
Okay, doctor.
Okay, go ahead.
Of course, here we have a swelling, but usually in exam we have no swelling, but it is the same. Just look into the submandibular area, right side and the left side. So can you just describe first spine inspection, and after that tell me what you need to do?
Okay, the side, it's the right side on the neck.
Yeah.
On the lateral side, it's the size 3 multiplied by 4 centimeter.
Yeah.
And there it's like potato shape.
Okay.
And it look like cystic formation.
No, cystic is difficult. It is just like, it's difficult by inspection to cystic. It is just round, it is just 7 by 5, whatever. Okay, what else?
Okay.
So usually looking for the right side, left side. This right side, left side have nothing. Okay, so this is by inspection. After that, you go to palpation. What you do in palpation?
I will make it. I will palpate the bulge, and I will.
No. Just take a permission from the patient to examine. So it's okay.
Yes.
Just ask the patient it is hurt or not hurt. After that, what you will do?
I will examine the lymph node in the neck.
No. Swelling first.
Yes, after the swelling, I examine the swelling.
You tell me the item, or you just one by one, up to you. Okay, so if you tell me the item, you examine the swelling. After that, you examine the lymph node. What else you need to examine?
After this, I will wear gloves, and I put my hand. I made by manual palpitation for the.
You make by manual examination for salivary gland. Okay, after that.
And I put my hand to palpate the duct, and I tell the patient with torch to see if any stone in the duct or any.
Okay, so you examine the duct and submandibular cerebral gland duct.
Submandibular.
What else you need to do?
After this, I will palpate the. I will auscultate the swelling by.
Okay. So you expected if you make auscultation, you have a mark for it or not?
Maybe I hear some bruit or something in.
No, just my answer in the checklist.
Yes.
What you expected that we put a mark for auscultation or not?
I think no.
Okay, so if you do something unnecessary, you lost your time, so no problem. The auscultation for lipoma, auscultation for breast mass is nonsense. Okay, so I just tell you, of course, if a thyroid swelling, you need to ask the patient to swallow, and the other, but because this is obvious, is submandibular swelling. If the station is neck swelling, you need, and the patient have no swelling, you ask patient for thyroid. But we concentrate now in the submandibular. After that, we go to the neck swelling. So you examine the swelling, you examine the lymph node, you examine the duct. That's it. No need for percussion, no need for auscultation. Okay. Usually the patient is simulated patient. Maybe in Cairo you can find the patient with submandibular, but most of the countries we don't find submandibular swelling. So can you start one by one just to go to inspection, go to palpation and tell me what you see in palpation and what you do in palpation?
I will see the temperature, I will see the tenderness, I will see the size, sorry. I will confirm the consistency, if it's connected to the yes, connected to the underlying muscle. It's
which muscle?
Sternocleidomastoid.
Okay, the sternocleidomastoid is not underlying muscle; it is more superficial, but you can see its relation to it, no problem. What else?
I see it's firm in consistency, or it's cystic.
After that, what will do?
I put the torch to see if it's to make sure the consistency inside.
You need to see it is cystic or okay. After that, what you will do?
After this, I will make by manual palpitation.
By manual palpation, not palpitation. Palpation you make by manual palpation. So what you palpate? If you put your hand, which hand you palpate the gland? Which hand you can see it is a lymph node? What is the value of this test?
The value of this test to see to differentiate between the submandibular gland and if it was lymph node.
Okay, how to differentiate between lymph node and salivary gland?
The outside hand try to feel if any lymph node and
okay, so the outer hand for lymph node and the inner is for submandibular. Okay, if you ask you can ask the patient one question because it's not a history station. If you can ask the patient one question to differentiate is it salivary gland or submandibular lymph node, what is the question?
Is the size increase while you are hungry or while you eating?
What type of food he eating can cause increase in size?
Before he eat?
No, what type of food he eat? What type of food, drink or eat can increase the size? Usually saliva is alkaline, so if you take sour or lemon or soya or something, so if you take something sour or lemon-like or vinegar, so that can increase in size. Okay, so this is by manual examination. You mentioned this is again by manual examination. And
عندي سؤال لحضرتك دكتور شيرين.
Yes.
In this station, the candidate usually will let him examine the patient, which is mostly an actor, and we don't intervene unless the candidate might cause harm to the actor. Which is a better system? Shall he give the immediate feedback of inspection, palpation, percussion, or leave it at the end and give a summary? Because I always get this question.
He sure he will fail.
Yeah, exactly. If you wait until the end, he probably will not remember.
Because he have two options. Maybe the time is gone and he have no time to present it.
Yeah.
And which is common. And sometimes he miss something he do in examination and he don't tell us.
Exactly, because I prefer
usually
yes.
the policy is you examine until, except if the examiner not to do that, but it is in rare occasion.
Yes.
Okay.
Yes.
All right.
This is very important.
The
Thank
mistake you. Because this is I attend many times. This station is very common. Okay.
Yes.
So back again to the Dr. Corolos. So after that, after bimanual examination, which is this and all this, so it is important to inspect by torch to see the duct. And I ask you, what is the opening of the duct? It is in the frenulum.
Besides the frenulum, yes.
Yes. After that, you miss something. You need to examine the teeth because usually submandibular stone and other. This is common with dental caries. This is again the site of the duct. This is dental caries in some patients, so it is important to look in for oral hygiene. After that, what you need to do?
I will palpate the lymph node.
Okay, palpation of the lymph node. You palpate it from the back. It is important, don't describe to the examiner. In some station, I found the students say, I go to the back to the patient, or some students say, I examine the gland. It is lymph node. It is examination of the neck lymph node, and you need to enumerate submental, submandibular, preauricular, postauricular, occipital, upper, lower, deep cervical lymph node. Okay, so this is the type of the lymph node. All right, so in some ENT, make it level, don't worry about that. What I see in exam, of course, in inspection, palpation, bimanual palpation. If you miss to examine the neck lymph node, we ask you any other area you need to examine. So it means the lymph node, neck lymph node examination is mandatory. No need to examine tongue for sensation. No need to examine movement of the tongue. No need to look in for the angle of the mouth for marginal mandibular branch of facial. Why we say that? Anyone? Why we don't need to do that?
Good evening, Dr. Sherene, because I think as we had the same station before, and you told us that the injury will happen after the operation, not before.
Yes, usually injury is happening after operation, not before. So this patient is not post-operative, so you don't do that. Okay. After that, we have some question we ask you. We can back to the Corolos. If the patient have a stone in the duct, how to manage?
I will make cyst trunk operation.
No, cyst trunk, doctor. Cyst trunk, by the way, is the name of person, and it is for thyroglosal cyst. Cyst trunk is like Dr. Muhammad Omar or Dr. Sherene. Forget the name. No cyst trunk operation. Marsupialization. You open the duct under local anesthesia and you deliver the stone.
Yes.
Okay. What I see in exam, some students say I use cystoscopy. I don't see cystoscopy in my life. Okay. What is the investigation you will do to see the stone in the duct or the salivary gland? What is the investigation?
I will make X-ray.
Panoramic X-ray, okay, can. Or for some mandibular salivary gland, it can be neck
ultrasound. Yes.
Ultrasound. Okay. All right. Okay. If the stone in the gland itself, what you will do?
I will make excision of submandibular gland.
Okay. So what the new guideline for incision? You make it for submandibular salivary gland. The new guideline.
5 centimeter below the mandible.
Okay. Nowadays, it is 5 centimeter below the mandible because in the past, in the textbook, it is only 1 inch or 2 centimeter or sometimes as the angle. So why we make this new guideline? Because in the past, it is very common to make the incision and you injure marginal mandibular branch of facial and the patient have drop of the angle of the mouth. so become cosmetic and not good or very bad. So nowadays they say we make it down 5 centimeter, although it is not good cosmetic, it is not good for the patient, but to make incision better than to make permanent lesion for drop of the angle of the mouth. Okay, this is easy station, very common station. Even in the exam 2 weeks ago in India, they come. The previous exam also in Dubai is come. In Malaysia exam also coming. So it is very common, and usually the student wastes the time for something like protrude your tongue, looking for sensation of the tongue, which is not logic. Ask to remove the tongue for hypoglossal nerve, and ask to blow or smile or show my teeth. Show teeth is for marginal mandibular bridge. Okay, so this is easy station. Just take it easy. Inspection, palpation, by manual palpation, examine the lymph node. That's it. Answer the question, and the question is either you remove the gland itself or open the duct, leave it open, and usually done by local anesthesia if you open the duct, and usually done by dentist, and the nerve we ligated or we injected or we sensitized is lingual nerve, and after that he caused lots of sensation for 2-3 hours in the anterior 2/3 of the tongue. The gland is removed totally. Totally, yes, it is removed totally if the stone in the duct, we don't open and remove the stone. If the patient have a stone in the duct, not in the duct, in the gland, we remove the gland. If have a stone in the duct, we open the duct and leave it open. Any
Just a quick question. Yeah. You're going to do a practical hands-on course in Egypt in September on 26 and 27. Is there going to be a submandibular auscultation training in this
yes, but I think also we may be difficult to find the patient with submandibular gland, even in exam. But
we can use an actor.
Yes, you can use an actor
I have
to
done
have
it.
show, but just the swelling.
Yeah.
Usually we do that, yes.
Okay, that's very good news.
Doctor, could I ask a question?
Yes, Dr.
can,
Iman,
Dr.
yes.
Iman.
Doctor, if I not see a swelling in the gland, could I ask the patient to pointing to the swelling or the site of abnormality?
Yes, can, but usually in the station, we usually tell you this patient have swelling in the right submandibular, but you are lucky today the swelling disappear.
But if I didn't found the swelling, so I just
which center you enter, Iman? Which center you go?
Maadi Hospital.
Are you from Egypt?
Yes.
Yes, from Egypt, I think it's difficult to find submandibular gland. In India, because India is a big population, maybe millions, maybe milliard, so it is easy to find all cases. But if you are in Malaysia or are in Egypt or some Middle East area, it is usually impossible to have a submandibular salivary gland. Yeah. You have the case, you have the scenario, you have the actor, but it's difficult to have a real patient.
I have examined this station multiple times in United Kingdom. They never get a patient. It's always an actor. And regarding
actor means they have no swelling.
Exactly. And they always tell where is the swelling to the patient. The actor is an instructor tell him this has disappeared today. This morning it has disappeared. And then you continue the exam. There is always a tongue depressor with this station, and we usually prevent the candidate from doing the tongue depressor because sometimes they do it little bit rough, and this will hurt the examiner. But at least he should get a mark that if you want to have a look at the palate or the canal, use a tongue depressor. But we usually prevent them. Is this what you do, Professor Sherene?
Yes.
Okay.
Usually you have wooden tongue depressor.
Exactly. Even with bimanual examination, when he wears a glove, start to do bimanual, we're instructed to tell them, okay, I will consider you done the bimanual and you can feel the swelling. But we prevent him actually from doing the bimanual on the actor.
Yeah, it's different from area to area and
Yeah,
different from
different.
actor
But
to actor.
in Egypt, they get real patient for thyroid because they are happy. They take
Yes,
fees per day. They get
yes.
real patient of submandibular gland because they are happy. They take fees. In Egypt, they can get you a real patient, but in United Kingdom, I have never seen a real patient. It's always an actor.
Yes.
Yeah.
Dr. Mariam, what you need, you raise your hand.
Prof, so when the patient actually says, the simulated patient actually says that the swelling has disappeared, so my findings, examination findings, will be as such of a no swelling, right?
No, no. Usually you say is most probably it is salidinitis or inflammation of the gland and already improved.
Oh, okay, all right,
All right,
all
okay.
right.
I think you are in UKM, Mariam. We have exam after 2 weeks in your hospital.
Okay, Prof.
So you can see the simulated patient. You can help if you wish. So
Okay.
will be a 4 day in your hospital.
Okay, Prof.
All right, okay. So it is nice to see you face to face. I don't see you before.
Yes, Prof.
All right. So anyone need to go to next? Anyone for this neck swelling, anterior neck swelling?
Same goes.
Okay, go
Okay.
ahead, Mariam. Yeah.
All right. So Mariam, this is a patient, 45 man, presented with anterior neck swelling, several year duration. So perform focal examination. This is the patient.
Okay,
So what you do first?
so I'll introduce myself and
Yes.
confirm the patient's identity, and
Yes.
I will explain the action I'm going to, the procedure I'm going to perform, examination. I'll tell him that I'll be examining him from front and back, and if
All
he
right.
has any pain, he should let me know, and if he's very uncomfortable at any point, he can let me know.
All right. By the way, in the most of the center, we have the patient person, so it is just for identity of the patient. So if you write Mr. Ali or Mr. Muhammad, so you can find the same name in the person. In some centers. Okay. After that, go to an inspection.
I will start inspection from in front of the patient. I'll keep the patient in sitting position, ask the
Yes.
patient to swallow.
Yes.
I'll provide the patient a glass of water and ask him to take a sip and swallow, see the movement of the swelling.
Yes.
And I will also,
If you see the movement of the swelling, what you say?
I will ask the patient to, if it move with a deglutition, I will suspect that this is a thyroid swelling.
Okay, so you need to tell the swelling after you give sips of water to the patient, hold in mouth, moving up and down, so the swelling move up and down, so it is most probably a thyroid swelling.
Thyroid cyst,
So
but-
this is by inspection. What else in inspection?
And since the swelling is on the side rather than center, I can actually move on without doing the protrusion of the tongue test, because the
Okay, so this is good. If the patient has the swelling side or lateral like this, so not necessary to do protrusion of the tongue because it is impossible to be something else.
Then I'll explain the size. This is a left-sided swelling, about
Yes.
3 by 4 centimeter.
Yes.
Surface of the skin surface doesn't have any signs of inflammation, acute inflammation.
Yes.
No ulceration. Seems to be a smooth surface, and I cannot exactly see a delineated margin at this point on inspection.
Okay, no need to mention ulceration because usually ulcer is very rare with thyroid, so no need to mention ulceration. After that, this is an inspection. After that, what you will
I'll
do?
move on to palpation. I'll start the palpation from front initially. I will check for the margin and tenderness. Size.
Okay, you can start from front. You can start from the back. Both are the same. What else?
I will measure the size of the lesion, margin and consistency with tenderness. I will observe if the patient has any pain symptoms on his face.
After that?
I'll move to behind. Do I move to behind actually? No, I can actually continue from front, right, Prof?
Up to you, but if you need to check the trachea, but you must be in the back because of the examination of the lymph node must be from the back.
Okay. So I'll move to the back and I will see the trachea if it is central.
No, trachea is from front. Back for lymph node. And also you need to see the end of the lower margin of the swelling.
I will see, on palpation, I will see if I can delineate the upper and lower margin, if there's any retrosternal extension or not.
Okay.
I will also check for any deviation in the trachea, and then I will move to back and no, lymph node is later.
Okay, so you examine the lymph node. But before that,
I will do percussion and auscultation. Percussion no need. Auscultation I will see to do to see if any bruit is there or not.
Okay.
Carotid
So
bruit.
I just remind in the examination of the thyroid, we have about 6 items.
Okay.
Of course, you make a size, shape, surface, smooth surface, movement with swallowing or deglutition. But when you palpate, you need to feel the lower part to occlude retrosternal extension. Surface is smooth, well-defined edge, consistency, soft. Looking for trachea, you put your finger here and looking trachea is deviated right side, left side, or central. Don't forget carotid pulse because carotid can be backward displacement. Of course, you mentioned lymph node. Okay. So again, it is according to the size. For example, this if big size can shift it to the other side, but it's not big. This is also, although it is big, but it is central. After that, percussion in the manubrium and auscultation.
Auscultation.
Okay. So back again. So it is important again to inspection, palpation, percussion, auscultation. Inspection from front, ask you to swallow, move up with swallowing. So it is thyroid swelling and no dilated vein, no apparent scar, no pulsatile or no pulsation. After that, you can go to from the back, examine the thyroid, size, surface, smooth surface. It is important to say it is not attached to the skin. Create the sternocleidomastoid muscle because this is sign of malignancy. After that, you're looking for the lymph node, you're looking for the trachea from front, and percussion, and then auscultation.
Okay, bro.
Okay?
Okay.
It is important when you examine to speak during the examine because either you forget something at examination or you do something and forget. Okay. Of course, after that, you need to evaluate. What is your diagnosis?
I will move further to examine if there's any eye signs or hand signs in
yes.
thyroid.
So either if you stop here, you say it is goiter left side. So I ask you, it is toxic or not toxic. So you can start after that by thyrotoxic manifestation. So what you need to look for?
I will look in the eyes to see protrusion of the eyeballs and a lid retraction in the eyeballs.
Okay,
in the else? Eyelids. And then in the hands, I will ask.
No, it's still in the eye. So first ask the patient to look forward. You fix it, look forward, looking for frontal wrinkling.
Yes, frontal wrinkling.
Lid lag. After that, conversion. 3. 4 is H shape. You can make it one by one or eye by eye or two eye together.
Okay.
So looking for frontal wrinkling for exophthalmos. Looking for lid lag. Looking for eye movement. Looking for conversion. You can look into the exophthalmos from the above the patient or from the lateral position. So it is very, very important to do that. After that, go to the hand looking for
clammy hands or dry hands. Then for
warm and sweaty hand and
yes, and then tremors. If
fine tremor, it is easy to be simulated. So you can find in this station behind the patient they have a piece of paper. So it is easy patient to simulate fine tremor. What else?
Then I will.
You need to look in for the leg. Sometimes they have peritibial myxedema.
Yes, I will move on to check the pulse of the patient if it is tachycardia or if there's any drop rhythm to exclude atrial fibrillation because thyrotoxic patients might have atrial fibrillation associated, then a peritibial myxedema.
All right, okay. You can ask the patient also about myopathy or muscle pain. Of course, it's not necessary to remember everything, but at least you remember some of them. It is important to, again, attach it to the skin, attach it to the muscle, or infiltrate the muscle.
Okay.
What type of thyroid cancer you know?
Papillary thyroid, follicular, medullary, and anaplastic.
Okay. I think Prof. Muhammad Omar asked, is peritibial myxedema is part of examination? Actually, it is part, but if missing by the student, no problem.
Okay.
Okay. But if you remember, it is better. Peritibial myxedema, it is with hyperthyroidism, although it is called myxedema, but it is not hypothyroid, it is hyperthyroid. If the patient is 20 years old, young patient, so which type of thyroid cancer they have?
Papillary thyroid.
Papillary, and it is important to know what is the papillary thyroid carcinoma look like. And this is again the picture with empty nucleus or orphan any cell and the moma body or macrocalcification.
Microcalcification.
Okay.
Yes.
All right. Thank you, Dr. Mariam. So again, examination of the neck or examination of submandibular is fixed station, is according to availability of the cases. In some country, easy to find thyroid case. In some country, easy to find submandibular case. If don't found, we bring a normal patient. And again, examination is inspection, palpation, percussion, auscultation. Carlos, what you need to say?
I want ask a question about the previous station. What's the role of tongue depressor in this station? The submandibular.
This station we don't have tongue depressor.
No. I mean the submandibular, the first station, submandibular gland.
Okay. Because when you're looking for the teeth for examination of the teeth.
Okay. Thank you, doctor.
Okay.
Thank you.
And just a good advice. I always advise candidate, have a look at the table in front of you. Sometimes it reminds you of something that you have missed. Like, for example, a torch of light. When you want to see the mouse, you want to see the teeth. And tongue depressor, as Professor Sherene Elhariri said, to move the buccal space. So for you to see any inflammation inside the mouse, you wouldn't be able to do that neither with your finger or with your bare eyes. So always have a look on the table, because the table have exact scenario for you to use. We do not put anything for luxury. If there is a tuning fork, then you need to use a tuning fork. If there is horoscope, then you need to do horoscope. So I always advise, have a quick look. It will take 15 seconds. What is on the table? What is your advice, Professor Sherene?
Yes, it is important. If he good observer, he can look to that.
Yeah.
Okay. All right.
Dr. Iman, have a question.
No, I wanted to take.
All right. Okay. So we can start. The third station, which is common.
I actually wanted to ask one thing. In case of large thyroid masses, do we need to elicit the Pemberton sign and SVC obstruction signs? Is it counted?
No, you mean this sign?
Yes.
No, it is only done in Malaysia. The other country don't know it.
All right, Prof.
All right.
I don't know this sign. Can you explain it, Professor Sherene?
This is the Asian people. They have a belief that if you put your hand like this and the back like this, too easy to examine the thyroid.
And Pemberton sign, SVC congestion signs.
Is it written in clinical examination books, this sign?
No, it is a traditional books, because usually in Southeast Asia we have Indian book like this. It is common in Egypt also. And these books, they usually have funny test.
Okay, Prof.
Okay, no need. See you in exam, inshallah, Mariam.
Inshallah, Prof.
Okay. All right. So Dr. Iman, this is a 65 years old man in outpatient clinic, complain of pain in the left lower limb. This is very common stations. It is some sort of peripheral vascular disease, and they ask you, can you examine the patient? Okay. So we usually have the patient leg like this. sometimes the patient is normal, or but in many countries it is easy to have patient with skin manifestation, at least for vascular peripheral vascular disease. You can start. So after introduce yourself by inspection what you are looking for.
انت اشتريتي حاجات للبيت كتير يا نسنوس، فقولي لي
Firstly,
كده
I
ايه،
will
حاولي جمعي واحده واحده.
a gait of the patient, and then I will.
No, actually, Doctor, gait is not necessary in the vascular disease. Because you know that from the start, if I say examine the lower limb outside, so we don't know it is orthopedic or it is a vascular. But usually, if I write here, clinic complete left lower limb, pain in the left lower limb after walking, or sometimes they call it is a vascular clinic just to avoid misunderstanding by students. So don't need to do the gait. What else you need to do?
I will do an inspection of the legs by
So what you see in an inspection of the leg?
By seeing the ischemic changes, like
what?
Like ulcers or
No, before ulcer. Okay, I tell you. Suppose I bring normal candid. Of course, is not normal, and I need to mimic ischemia. So what I do first in this leg?
The temperature and the color of the skin.
No, it is difficult to change the temperature. What else I can do?
Color of the skin.
Color can. What else?
Hair.
Remove the hair. Okay. So it is important because, of course, we don't make an ulcer of the patient. It is unhuman if this not a real patient. But what we can make it, we just remove the skin from one leg. Suppose I need to make it right, left, so I just remove hair from one leg, so it is easy and is not big problem. So first looking for the skin loss, for the hair loss. What else?
And the muscle atrophy.
No, muscle atrophy at the end. Hair loss and shiny skin and
dry shiny skin and the thin and atrophy of the skin.
Dry skin. Okay, what else? Infection between toes and any wound or ulcer.
Okay, I will inspect for the tip of the tooth and between it.
Yes, and the nails also. So I just remind you, looking for the skin, first loss of hair, any wound or ulcer, any infection between toes, any muscle atrophy. After that, you're looking for any pigmentation like this, brittle nail and the other. After that, what you will do, so this is inspection. After that, what you need to do? Palpation.
I will do palpation by doing temperature.
Temperature, so maybe cold if it's a real patient. What else?
And then the tenderness.
Sensation also, tender, okay, sensation. And
also I do peripheral pulsation.
Peripheral pulsation. Okay, so for peripheral pulsation, so again, just to summarize, looking for the skin, looking for hair loss, looking for shiny skin, or lipodermatosclerosis is venous hypertension, looking for any infection between toes, looking for brittle nail. After that, by palpation, looking for local temperature, and looking for a test for sensation or loss of sensation. After that, you have how to measure the what's called the how to feel the pulse.
By doing palpation of the dorsalis pedis artery.
Okay, but usually in exam we have handhold Doppler to be easy. Okay, so where you dorsalis pedis, where you feel it?
Between the first and the second tooth.
No, between the first and the second, it is vascular exposure, but to palpate must be over bone, so it is lateral to extensor hallucis longus.
Okay.
So you can ask the patient, to, suppose this is the big toe, ask to make it up, and it is, you can find extensor hallucis longus, and you can palpate it over the navicular bone. After that, posterior tibial, where you feel?
Between the medial malleolus and the heel, Achilles tendon.
Between
it.
no, I think easy to between medial malleolus and the calcaneus because can no problem. Can.
But
After
it's not
that,
something. Okay. After that, we can do anterior tibial artery, but it's difficult to.
no difficult. Don't do it. Popliteal sometimes is difficult, so go to straight to femoral.
Yes, and then femoral.
Okay, but if you have both is okay, no problem. Dorsalis pedis posterior tibial is okay. Of course, in the exam, mandatory, we have hand hold Doppler. Of course, you make it on, you have special type of gel for ultrasound, and they put external lateral to extensor hallucis longus after you make dorsiflexion of big toe, and between the medial malleolus and calcaneus for posterior tibial artery.
So,
Okay.
doctor, we will do palpation and then use a handheld Doppler for the artery, or use the.
No, it is up to you, but I think it's better to put the handheld Doppler first.
Okay, but handheld Doppler will used in ankle brachial index, not full full auscultation for all the arteries.
No, it is used for both.
Okay.
Okay, so what else you can't do? You either do Berger test, so you elevate the leg, looking for the dorsal of the foot, and after that make it down, so become hybremic. Second, we ask you to do ankle brachial index. When you do ankle brachial index, you have sphingomanometer, and you use Doppler also.
Okay.
All right? Okay. After that, we show you X-ray or angio. Yes.
Auscultation for the abdomen, for the iliac artery and the femoral artery and the aorta.
Actually, we don't do auscultation for all this, but if you need to make abdominal examination to exclude aortic aneurysm, if this patient have bilateral, okay. We don't auscultate the aorta in the abdomen, it is very difficult. We don't auscultate iliac, it is impossible. I think only femoral by Doppler is okay. All right. But if you ask you what else you need, if this bilateral, so you can looking for aortic aneurysm or something like that. Okay. I just have a picture, so you can looking for this lipodermatosclerosis, not for ischemia, it is for varicose veins. This is pale patient and the mottling ink. This is for ischemia. After that, of course, this is angio. And as you see, this is obstruction in the popliteal area, and it is clear. And usually balloon dilatation, removal of the thrombus, and the put a stent. Okay. Don't forget, usually stay on the right side of the patient, not left side. This is wrong. Okay. All right. So, any question about this case? This is very common because ischemia is common all over the world.
Yes, Dr. Sherene, do you start proximally from the femoral artery to distally, or you start from the dorsalis pedis and posterior tibia?
The logic is to start from dorsalis pedis because you go from distal. If dorsalis pedis is not felt, posterior tibia not felt, so go to the femoral. So it is better to come from distal to proximal. All right. By the way, in exam, we don't interested much about what you will do. We have a checklist. What you will do, we make it. Whatever the order, not a big deal. Anyone, we have another case. It is varicose veins. Varicose vein, sometimes in the country, like you can have white people, like in Egypt, you can do it, but in some country like India, or black races, is difficult to see varicose vein because of the color. So this scenario is 55 years old woman working as a chef in a restaurant because of long standing, complaint of dilated vein on the lower limb, examine the patient. Okay. So anyone can start?
Okay.
Okay, can. So what you looking in varicose veins? First, by inspection, what is the position you need the patient to sit or stand or what?
First by standing.
Okay.
Then I will look for dilated veins.
Yes.
and if dilated veins around the ankle, and also for the chronic venous insufficiency.
No. Just the dilated vein. Which system you're looking for?
Dilated veins.
Which system? Like, for example, you're looking to the patient leg and say this is in the course of long saphenous. This is on the course of short saphenous. Okay.
Yes.
So if medial is long saphenous is lateral and short saphenous. After that, what you're looking for? Looking
for lipodermatosclerosis or eczema.
So pigmentation or lipodermatosclerosis or any venous ulcer.
Or blew out or saphenopharynx of the saphenous.
Blew out or saphenopharynx up, and after that, of course, in any examination of the lower limb, also you need to examine for varicose vein, for arterial supply. Okay, so go to one by one. So, for example, you can see this patient. So, what is this system? Long or short saphenous?
Long saphenous vein.
Long saphenous. Okay. What does varicose vein mean?
It's a dilated, elongated tortuous vein.
Dilated tortuous vein. So this is long saphenous. In this situation, it is better to do Trendelenburg test, just single tourniquet test, no need for multiple tourniquet test, just looking for saphenofibrillar junction discontinuity. And again, you can put your hand or you can use the Doppler. If it is short saphenous, you can make it in popliteal fossa, and again, you can use the Doppler. After that, looking for any pigmentation or beginning of venous ulcer, what we call it lipodermatosclerosis due to venous hypertension. After that, if patient have an ulcer or a picture of ulcer, you need to describe the ulcer like site, size, shape, sloping edge, color, healthy, granulation tissue or infected, and the skin around, usually lipodermatosclerosis. This is what we call it lipodermatosclerosis or pigmentation. Again, we have handhold Doppler. You can use for saphenofemoral junction, can use for short saphenous with popliteal artery, popliteal vein junction. You can test arterial pulsation, usually do that. Okay, how to treat this patient? If the patient have varicose vein or venous ulcer?
Okay, by doing this exercise and elevation of the legs, and by wearing a stocking.
Yes, it is varicose vein stocking, so it is different from TEG stocking used for DVT. Okay, what else?
And drugs for strengthening the wall of the veins.
Like what?
I know the generic name. Daflon.
What is generic name? Daflon? Daflon, yes. Daflon is diazomine, 500 milligram. So Daflon is diazomine, no problem. All right, okay.
All right. Then we can do less invasive surgery like a radiofrequency ablation or the laser.
No, don't think simple. If you make a stripping, you make it to which level?
Above the knee.
Why above the knee? Although in the old book it is below the knee. So why now it is recommended to be above the knee?
To avoid the injury of the saphenous nerve.
From where the saphenous nerve coming?
From the femoral nerve.
Femoral nerve, and if it is injured, he can loss of sensation in?
Medial part of the side.
Yes, or area related to the big toe. Okay, so now stripping is done till the mid thigh is okay. If you below it in the lower limb, below the knee, what you will do for these varicosities?
Phlebotomies.
It is multiple avulsion technique or phlebotomy, and after that we have bending it. So multiple avulsion technique or many avulsion technique. It is something like this. This is multiple avulsion below knee, and just have a hole. No need to make a stitch. You just can have a strip or something. You see this picture?
Yes.
Yes. So multiple avulsion below knee. Okay. All right, this is the saphenous vein. If have injuries, so can have loss of sensation in this area. So back to you again, Dr. Iman. It is important not describe something very advanced, like you need to mention laser. What else you need to mention?
Radio frequency.
Okay, so this is, of course, you're supposed to be young doctor and like what we called it, like not much experience. So if you need to speak, just speak in classic way. You can add, if you need to add, I can local injection of sclero material or vasoconstrictor material or sclerotherapy can, but laser, I don't know if you are vascular, it is common in your hospital or not. Radio frequency, I don't know it is common in your hospital or not. So it is according to which country you are. If you are in Dubai, for example, so you can do that, maybe see it in Dubai or Emirat or something. If you are in India or other country, don't see something so funny. Maybe in some country they don't know about it. Okay, so don't say something too advanced. It is not make the examiner proud with you. He don't know this. Okay.
Okay, doctor.
So just take it easy.
Okay.
All right.
Yeah, thank you very much. That was a great session, Professor Sherene. I just want to make
Thank
a
you.
quick survey.
Yeah,
We have 5 candidates. To reply yes, you can raise your hand. To reply no, don't raise your hand. How many of you want to work in United Kingdom after passing MRCS? If your answer is yes, raise your hand. I can see Dr. Corollos, Dr. Nabhan,
Yeah.
Dr. Abdurrahman. Okay. Now, Dr. Aman and Dr. Mariam, what you're going to do after passing MRCS? What is your plan? Dr. Iman?
Actually, I don't know.
You don't know. Okay, well, that's fine, because I think one of the course we're going to give a career advice. Career advice to help you what you need to do with your career. What about Dr. Mariam? You're going to work in your country.
After masters, I'm currently doing my master's program here in Malaysia.
Okay.
After that, I'll try to directly go into super specialization here if I get a slot.
Okay.
Then I will think about abroad.
Excellent. Excellent. Very good. Okay. So let me take you to the second question. How many of you want to practice surgery as a general rather than other specialty? Because some people take MRCS just to go to a job in United Kingdom and become medicine.
For registration.
Just for registration. Okay. So okay. So Dr. Nabhan, Dr. Corollos is going to work in surgery. So if you raise your hand, which means that you are in surgical career, none of you want to go to medical career after passing MRCS because it is easier than the lab. Is that right? Yeah, okay, that's fine. So I just want to make this quick survey. I think most candidates want to pass MRCS, and most candidates want to continue in the surgical career, because it will be a shame to have all this basic information of surgery and then to start to go to cardiology or neurology. Back to you, Professor Sherene.
Okay, I know we're about to finish. So again, clinical examination, it is important, especially in management. Don't say something so advanced, because last exam I was in India. I found in India we examine about 400 students. Majority of the students speak about submandibular. What you do for investigation, I do salography. How to remove the stone in the submandibular duct, I use saloscope. And actually, I know, of course, we have good knowledge about Indian hospital. We don't have saloscopy in all Indian hospitals. So this is something like magic. So it is important according to country where you are from. I know that some country like Malaysia is advanced. Some country like Dubai is more advanced. But don't say something the examiner sure that you are not see in your life. So sometimes they ask you about detail of this. So don't ask about this. It is the same like when you ask about varicose veins, what's called the radio frequency. Maybe the examiner have interest to know how to apply radio frequency in the varicose vein. He need to learn from you, and they found you have knowledge. By the way, Dr. Iman, you see radio frequency for varicose vein or not?
Actually, no.
All right, okay. Maybe in Egypt, I think they have it. I know that Egypt have all the advanced, but it is important. Don't see something advanced and you have the impression that we embarrass the examiner. We tell him something so advanced. It is not our policy. We know that this exam is inlet exam. It means that you are beginning your career. It is not a master, not MD. So don't say something so advanced, so funny. Usually don't done. I have exam today, one from Maldives, by the way, from Mariam, and the candidate speak about